Once again, welcome to the last segment of these lectures on management of cirrhosis. Now, cirrhosis is just mentioned in relation to the liver. And so when you hear somebody talk about liver cirrhosis, perhaps they don't understand the concept. So cirrhosis is what we'll be discussing. We had looked at acute viral hepatitis and chronic viral hepatitis, and now management of cirrhosis. We will be starting shortly, and I'll be sharing the screen again so that you're able to see and participate, so that if there's any word I'm not pronouncing well, you will be able to capture them on the screen right away. And again, I would likely be sending this onto YouTube so that you're all able to access it when you need to. So let's go ahead and start demonstrating what I will be talking about. Some others I'm aware might be getting the time wrong because of the fact that we're accessing this from different countries. But I'm hoping that they will understand this and be able to go through without any crisis or confusion. Brilliant. Thank you very much for coming and joining me. Right, so management of cirrhosis. Cirrhosis, again, is when the liver has become replaced by fibrotic tissue, and it's a complex definition which I will make it easy for us all. At the end of this presentation, we intend for participants to be able to understand what cirrhosis means, to also be able to recognize how it should be treated or what would happen if you don't treat it, and then to identify the various complications of cirrhosis and discuss the management strategies of those who have compensated cirrhosis. Okay. So what is cirrhosis? What do you understand when you hear the word cirrhosis? Does it make any sense at all? Is it a death sentence? What can we do about that? Okay. So cirrhosis is simply defined as four things, really. Okay. Marked degeneration of the liver, inflammation, fibrous thickening or scarring of the liver, and there is nodular regeneration of the liver. In other words, the liver has become so inflamed that it's beginning to scar. And then there's an attempt by the liver to regenerate itself, but instead of doing it well, it becomes in a complicated nodular fashion and thereby leads to liver failure. Okay. So what are the common causes of cirrhosis? I will look at this from in the developing countries. Hepatitis B, C, and D would be most relevant. However, in the developed countries, alcohol abuse is very, very significant. Nowadays, as people, are living longer, the non-alcoholic fatty liver disease has emerged as an important cause of cirrhosis. So you must not be drinking alcohol for cirrhosis to happen. Okay. There's a situation known as hemochromatosis. It's a genetic disorder in which iron storage is not well handled, and that can lead to cirrhosis. Additionally, there's autoimmune hepatitis and also a deficiency of an enzyme known as alpha-1 antitrypsin, primary biliary cholangitis, and primary sclerosing cholangitis. Rarely, some drugs such as methotrexate or isoniazid could be causes of cirrhosis. Okay. So the things, because there are many complications of cirrhosis, we shall discuss the management of a few of these. And there's about 5 of them. We talk about, gastrointestinal hemorrhage, that is bleeding, ascites, which is excess accumulation of fluid in the abdominal space, a spontaneous bacterial peritonitis, that is inflammation of the lining of the abdominal wall, hepatic encephalopathy, this is a neuropsychiatric disorder, and then liver cancer, we call that hepatocellular carcinoma. Now, don't be scared. This lecture is going to finish within the next 20 minutes or less. So we shall just have a tip of the iceberg introduction into these matters, just so that the public can understand what we're talking about. Right. So what are the common causes of gastrointestinal bleeding in patients with cirrhosis? So when the portal hypertension has developed, uh, there is an attempt by blood vessels or blood flow to shunt the liver and thereby opening certain alternative routes of blood flow to the heart. And that's when blood vessels become engorged within those alternative routes. And the most common one is the junction between the food pipe, that is the esophagus, and the stomach. Okay. Now, these are when they become too engorged, then they break open and bleed. You've got those gastric varices as well within the stomach area. And then you have portal hypertensive gastropathy. Very rarely, patients with cirrhosis also have a higher tendency to developing peptic ulcer disease as well. So those can contribute. And there are cases of rectal varices reported. So how do they present? Commonly, bleeding. I apologize in advance if you don't like these images, but this is when somebody just vomits blood. It's not a sight you want to see a patient present with. It is torrential, it is very frightening, and it could be catastrophic, okay? And then passage of black tarry stools. Now, when vomiting of blood is much more common when it's the oesophageal varices that has broken open, and if there's massive bleeding that is coming slowly from the stomach, it can be passed as digested blood in what is known as melena. The patients will be very sick, tachycardia, that is, pulse rate would be high, blood pressure will be dropping, and unless it is adequately managed, they are more likely to die. So there's something that needs to be done quickly about that. How do you treat them? You go in endoscopically and apply band ligation to the varices. Here you can see the bands applied, and that has stopped the bleeding there. Okay, that's post-banding. And here you see the varices here, and you can see sclerotherapy. You inject sonlopoidal chemical, and which will then sclerose the varices and make it less bleeding. In advanced centers, a particular equipment, a tube, is passed between the systemic circulation and the portal circulation. Here you see the portal vein within the liver. So it is transjugular because you pass through the jugular vein right down and into the hepatic vein. And then that stent connects the portal vein to the hepatic vein. So it's known as transjugular intrahepatic, that's within the liver, portosystemic shunt, portal because portal vein and systemic, okay? Now this will decrease the pressure and thereby collapsing the engorged blood vessels and less tendency to bleed. The complication with this, however, is that the patients have a likelihood to develop hepatic encephalopathy as the hepatic toxins are given direct access into the brain. Okay. However, there are mechanisms to prevent that. Let's go on to ascites. Okay. There are many theories. I knew many of the students I taught will have been asked these kind of questions over field theory, under field theory, but we're not in an exam situation, and I don't expect anyone will ask me to explain these theories. However, the vasodilation theory is the most upheld internationally. It's a theory, but we do know that the overall outcome is that there is excess retention of sodium, salt, okay, water retention, and then there is constriction of blood vessels within the kidneys. And these are the mechanisms by which treatment is administered to patients to prevent the excess fluid accumulation. This is a patient demonstrating tense fluid. It's not a pregnant person, okay? How do you treat them? You go on with diuretics, okay? Spironolactone will do two things: excreting excess sodium, and also antagonizes aldosterone, which is one of the effects of those dynamic changes that happen when cirrhosis occurs. You start with a slow dose and intend to get the patient to lose about 500 grams a day. This is if they have only ascites. If there is associated fluid collection in the legs, then you intend for them to lose about 1 kilogram per day of weight. If despite going up to the highest dose of spironolactone permitted, that's about 200, and they're not responding well, you can add furosemide. Furosemide is a loop diuretic and has a higher chance of making the patient develop acute kidney injury. So you don't want to rush into that initially. Ensure that the patient is being followed up and monitored for any deterioration in kidney function, because you don't want to create that as well, as that will kill faster than the ascites itself. If despite optimizing these and the patient is not responding well, you go on to paracentesis therapeutic. In other words, you put a tube that would drain the excess fluid, replacing with, for each 200 mils of fluid drained from the abdomen, you replace by 20% human albumin solution, about 100 mils. This will prevent further deterioration in kidney function and or hypotension, which can kill the patient as well. The last one is, we mentioned these tips again, transjugular intrahepatic portal systemic shunt. Here you see the shunt again between the hepatic vein and the portal vein. That will reduce the portal pressure, and then the fluid will be decreased from within the abdomen. Right, so that is that about ascites. Spontaneous bacterial peritonitis is next. This is defined as infection of pre-existing ascitic fluid, that is excess fluid within the abdomen without evidence of a secondary source. In other words, if somebody has had a perforated viscous or intestine or any abdominal structure and develops an infection of fluid, that is not primary. That's not spontaneous, in other words. That is secondary bacterial peritonitis. But here we're dealing with spontaneous bacterial peritonitis. The clinical features would be a patient who has an existing ascites, has fever, abdominal pain, and tenderness, and all getting confused. How do you diagnose? They would present, you take a history and take a small amount of the fluid and send for cytology, just looking at the cells within the, and also look for cell count. If you have neutrophilic cells being high, that's polymorphonuclear cells beyond 250, you can diagnose straight away and start giving antibiotics. However, in some centers, they can go ahead and have a culture so that you are able to identify the organism and sensitivity so that you can give treatment as appropriate, targeted at the organism. Treatment is prompt commencement of antibiotics. The good news is that this is reversible, and it will be helpful to just get the patient treated. If the patient is not treated, then of course the chance of deterioration is high and death is likely. Next one is hepatic encephalopathy. What does that mean? This is a potentially reversible neuropsychiatric abnormality seen in patients with liver dysfunction. There are many theories, but the most upheld is excess ammonia bypassing the liver into the brain, thereby causing some dysfunction of brain function. So what are the precipitants? What are the things that can make somebody have hepatic encephalopathy? Spontaneous bacterial peritonitis, which we discussed already, gastrointestinal bleeding, infection from any source, kidney failure, constipation. These are the most commonly reported ones. The features will include disturbance in sleep patterns, hysteresis when the hands cannot be sustained, it falls easily, or hyperactive deep tendon reflexes, abnormal posturing, and sometimes patients come in coma. Bless you. How do you treat them? Treat the precipitants. Somebody bleeding, stop the bleeding. Constipated, give them some medication that will get rid of the constipation. You can use lactulose. The intention here is that they are able to produce about at least 2 or 3 bowel motions a day. That way, the constipation would be relieved and it tends to improve their symptoms. Rifaximin can be used as well. Next would be hepatocellular carcinoma. Now, liver cancer is a big subject. And of course, as for some of you who know me, has been the subject for which I had a PhD, looking at metabolic profiling. But the most important ones that we know are causes are cirrhosis from any cause, okay? Particularly if the cause of the cirrhosis was from hepatitis B, hepatitis C, or non-alcoholic steatohepatitis and hemochromatosis, then there is a high chance that it can progress to liver cancer. Although this is not very common, so don't be alarmed. But there's a second category I want to mention, that although many patients with hepatitis B who go on to have cancer are due to cirrhosis, there is a category of hepatitis B patients that can go on to having liver cancer without having cirrhosis. Now, again, don't be scared. This is something that does happen. I had made a post about how this happens on my blog, on my website, which you can find the categories of people who are at high risk of having liver cancer, which means they should be carefully monitored in order to prevent this, okay? So in other words, somebody is being treated for chronic hepatitis B and without any notice or sign, suddenly they present with the deterioration on what is it? Liver cancer. Again, this sounds scary, but please don't feel so, because this is something that does happen and could be monitored. Many of those who present with sudden deterioration is because they were never monitored at all. Aflatoxin is a toxin that is often available in foods that are consumed that are poorly stored. All right. Now, if somebody has cirrhosis from Wilson's disease or autoimmune hepatitis, these are not very common conditions in developing countries, then their chance of liver cancer is lower. Okay, right. Now, how does the patient present who has liver cancer? Because the liver is enlarged, when they eat small amounts of food, their stomachs get filled up. They have obstructive jaundice, and there is a mass within the abdomen with bruit. Bruit is a sound of murmur you hear over an organ due to excess blood supply. And that's what happens. But this is not common in all patients. Of course, if you examine them, some of them would have stigmata of chronic liver disease. Again, I've handled this stigmata in one of my lectures on chronic management of hepatitis or hepatitis B. The investigations are alpha-fetoprotein. Now, this is a protein that is available that has a low sensitivity, but if present, can actually increase your prediction that the patient may have liver cancer. Note that alpha-fetoprotein could be high in pregnant women. It could also be present in just chronic inflammation of the liver without liver cancer. So it is not reliable. The best test would be to undertake an ultrasound, which can find and show a shadow, and a CT scan or an MRI. Dynamic imaging with characteristic washout will demonstrate the presence of cancer. If it is indeterminate, then liver biopsy targeted at taking a sample from the nodule will make a diagnosis for you. How do you treat liver cancer? It depends on the stage. So we have the Barcelona Clinic liver cancer staging system that looks at the functional status of the patient as well as the size of the tumor and metastasis to be able to make a treatment advice for such patients. So liver transplant is the treatment of cure. There's one local regional treatment, such as radiofrequency ablation, which could potentially cure patients. However, there are other treatments which could be available in developing countries. Percutaneous ethanol injection, sorry, not infection, injection could be given to patients, and that does help reduce symptoms and slight prolongation of life. But some few studies from developing countries have not demonstrated any particular advantage apart from decreasing pain. I did some little bit of work when I worked at Jos University Teaching Hospital in Nigeria. I can confirm that it did help with pain management. But in terms of how long the patients lived, it wasn't that impressive, although there were a few months longer than those who did not have any treatment at all. Transarterial chemoembolization is when you insert a catheter into the artery supplying the tumor, and you embolize the tumor with some chemicals that also can kill the tumor cells. That is palliative and does not have any particular additional advantage, but it does occasionally help in downgrading the tumor for some therapeutic outcomes management. Okay. Best support chemotherapy is available. Again, very poor, but it does help. In our experience, if a patient has a diagnosis of a liver cancer and is not within the region of liver transplant, the chance of survival is really low. Okay, within 6 months, they die. Of course, if the liver itself, the liver, the other liver is healthy, for example, like I mentioned, if somebody has hepatitis B and without cirrhosis, in other words, the segment of the liver is healthy, whereas the segment that has the cancer is not healthy. They can, and the size of the tumor is small enough, there could be hepatic resection. In other words, one of the lobes that is harboring the tumor can be resected surgically, and the other lobe will regrow and replace the other lobe that was taken out. That is curative. Okay? Cure in medicine is very difficult to define, but recognize that that is one of the things that we can do for patients in this scenario. So what have we talked about today? Cirrhosis is when the liver has become replaced in most parts by fibrous tissue, nodular regeneration, and distorted architecture of the liver. Okay, it leads to end-stage liver damage via complications such as gastrointestinal bleeding, ascites, hepatic encephalopathy, spontaneous bacterial peritonitis, and so on. There are many other complications we have not discussed due to the time limit of this lecture. Dynamic changes in blood supply to the splanchnic circulation underlie the pathophysiologic changes in cirrhosis. Of all the theories, the vasodilatation theory is the most important. Okay. Lastly, management of cirrhosis is aimed at identifying and managing these complications. Otherwise, the ultimate treatment is to transplant the liver. I think you've stayed and done very well to be with me at this lecture. I will congratulate you all for participating and actively so. I will be sending to your emails how you can get silver and gold membership, and then you will be given access to downloading these slides if you think you need them. Otherwise, my commitment to teaching is not bound by funds, but we would like your support so that we can continue to be relevant onto many people who need our support. Thank you very much, and I will open up for questions so that we can go on from here. You can unmute yourself if you want to say something. Thank you very much. Good. Yeah, so there's a comment here from Nanma about obviously the best option is prevention. Yes, so that is a very noble contribution there. For those who may not have had the viruses, yes, prevention is key. But if you've got the, in other words, liver cancer is one cancer that is preventable apart from the cervical cancer. We've got vaccine for that, but if you've had the infection, then you need to be monitored. There are algorithms for monitoring, and that I will encourage people to access those information. Yes, Nanlock, do you want to say something? I hope I didn't take you by surprise, but anyone and any person who wants to say something will be fine to go ahead. If you want to ask questions, or you can actually show your video and go on from there. If you want to contribute anything, I'm happy for you to contribute. I'm happy for you to ask questions and or make comments. Either I have bored you with too much information, or I have said things that have made you unhappy. Hi, Amy.
Yeah.
Yes, we can hear you. Brilliant.
I
Thank
have
you.
a question about the cirrhosis. If cirrhosis has already started in a patient,
Yeah.
can the antiretroviral stop it from progressing?
Very good question. Yes. So there are reports of cases when a scarred liver has actually recovered when they were given treatment. But this is important if the cirrhosis is at early stage. When the compensation has set in, it is very difficult. Be that as it may, there were cases of patients with cirrhosis from hepatitis C and with actually excess fluid collection, that is ascites, who got well and their livers completely returned back to normal when they had the treatment for decompensated cirrhosis using antiviral agents. So yes, there are reports coming through that it could actually potentially be reversed, but it's not very common. I hope it answered the question.
Yes.
Thank you very much. Thanks, Amy. Any more questions? We'll give 1 minute and maybe some questions will come through. Otherwise, I will want to say I appreciate all of you for sacrificing your weekend and listening to me. Some of the comments and instructions might be sounding like babbling, but I do understand many of you here are not afraid to tell me off if I am saying something that is not appropriate. You would have told me what I should say better. I have tried as much as possible to use the simplest of English to explain a bit of some complex medical jargons so that you're able to appreciate what I'm saying. But should there be any ambiguity in any words that I would have used during this presentation, please do not hesitate to reach me via the email that you have on my website. And again, I will be sending you information from after this lecture so that we're able to keep the interactions ongoing. You look forward to additional resources and or planned lectures, which I would want to, when I send you feedback forms, please nominate and indicate what aspects of lectures you want some information on. We can plan further interactions like this. Thank you very much. God bless you.